Is good. Now let's keep the energy level and proceed with the rest of this the information. So next we have Dr. James. Dr. James, no relation to Donna James, except I would be happy to be a part of his family or have him a part of mine. He is a general obstetrician and gynecologist and associate clinical professor in the Department of Obstetrics and Gynecology at the Ohio State University Wexner Medical Center, and he supports services for teens at Nationwide Children's Hospital. Get to work with him myself in the work we do at the Center for Healthy Families. He's a great partner in working with teens. He earned his medical degree with Washington University in St. Louis, completed a residency training in pediatrics at the Nationwide Children's Hospital and the University of Texas Houston, in obstetrics and gynecology at the University of Texas Houston. Between 1992 and 99, he led a community-wide effort in Kalamazoo County that reduced black infant mortality. This is a key area of focus for us. His efforts helped that community become one of a few counties in the United States to accomplish the Healthy People 2000 goal of 11 deaths per 1,000 live black births. He's a well-recognized national expert on this issue. We're fortunate to have him in our community, and the timing was nothing but divine intervention for him to be in our community at this time to help us with this issue. So my good friend and colleague, Dr. James.
Thank you. So thank you all very much. I'm just overwhelmed by this, and I was just standing there by the wall saying to myself, how cool is this? Last week, the Association of Maternal Child Health Programs had its annual conference in Washington, D.C. So I got to interact with a lot of people from all across the country who are working on, in part, infant mortality projects, different degrees. And I kept pulling up on my smartphone the graph you saw of our goals and putting that in front of people, and everybody that I talked to, no exception, was jealous. Because this is revolutionary work that we are pursuing here. It's extremely important. Keep in mind that every day the future of our city is born, every single day. And that's what we're fighting for when we look to improve infant mortality. So I want to thank the task force. I want to thank President Ginther. I want to thank my colleagues and mentors, Dr. Peck and Chad Abrish, for gracing us with their presence and helping us to get this going. But I also want to thank the citizens of this community and the people of the state of Ohio for embracing and taking on infant mortality as a challenge. I think everybody knows this, but just to keep us on the same page, that infant mortality is the death of any live-born baby prior to his or her first birthday. And it's one of the most sensitive indicators we have for social well-being. These are the clinical causes of infant mortality. Dr. Peck kind of went over some of these. You also have seen them on the diagram that Donna James showed earlier. It's not so important to me that you remember all of this, except for the following. We, with regularity, coach infant mortality as a clinical issue, as a clinical problem, and we regularly talk about it in clinical terms: prematurity, congenital anomalies, sudden unexpected infant deaths, etc. So this is that pie chart that talks about the percentage of those clinical diagnoses that contribute to those babies dying in their first year of life. In 2010, if you looked at the 50 largest cities in the United States, Detroit and Cleveland were tied for the highest overall infant mortality rate in the country. And as you can see, Columbus was 15 on that list. So relative to other cities of comparable size, we have not favored well in terms of infant mortality from a national perspective. I'm going to go over some numbers, and I know we get tired of graphs, but I want to point out a few things. So this bottom line is our goal for where we want infant mortality to be by the year 2020, so out here. The green line is the infant mortality rate for the United States, and this goes from 1990 to 2011. The red line, the overall infant mortality rate for the state of Ohio. Note that we started out in 1990 with a gap between Ohio and the rest of the nation, and that as we've moved forward, that gap has widened. And in 2010, the last year for which we have data, national data that allows us to compare states by race, even though Ohio delivers the seventh largest number of babies per state of all states in the United States, in 2010, our white infant mortality rate ranked us number 38 out of 50. Our overall infant mortality rate, number 47 out of 50. And our black infant mortality rate ranked us next to the worst state in the country for a black baby to be born. That's us. Now, I would suggest to you, and I've gone across the state suggesting that those rankings don't represent who we are, that we are better than that. We are fortunate in our state that the governor has heard our call and invested substantially more to infant mortality, that the Ohio Department of Health has made infant mortality one of its top 4 priorities for our state. And I'm happy to see this, to suggest that within the great cities in the state of Ohio, that Columbus is going to lead the way to changing the way the rest of the nation sees us in terms of this perspective. So Ohio and the United States, let's add Franklin County to this data. And for our overall infant mortality rate, that blue line is where we stand. So think about what I said about where Ohio ranks relative to the rest of the country, and then look at where we are. As Dr. Peck has already said to you, we can do better. We will do better. We have to do better. These are our babies. These are babies that we are responsible for. So if we take a little deeper dive into that blue line for Franklin County, the graphs get complicated. Let me just walk you through it real quickly. The green line here is the overall infant mortality rate. This beige line, the white infant mortality rate. The orange line, the Hispanic infant mortality rate. The blue line, the all other infant mortality rate. The line up here, the black infant mortality rate. Simplify the graph. Here's the black infant mortality rate for Franklin County, and then there's a group of everybody else. Our interest is improving the infant mortality rate for the big group of everybody else, but also improving the infant mortality rate for black babies in our community so that the black rate joins the rest of the group. Can't make it any more simple than that. We have some outliers, and we want them to be part of the collective. So if we concentrate on that black-white rate, we can see that going from 1990 to 2012, we've had this huge gap. And I think you can tell we don't see much evidence that that gap is improving. If we were thinking about infant mortality as a race, and our thoughts were that we wanted the runner who was behind to catch up with the rest of the group. Then in terms of running the race, our task is to help the runner who was behind learn how to run faster than the rest of the group in order to catch up. That makes sense? And we want to do that by not asking the group that's in front to slow down. We don't want the runner who was behind to catch up because the group that was in front slowed down to let him get with the rest of the group. Where the rate at which babies are dying are concerned, we want to do the same thing. So we want to continue to improve the infant mortality rate for that group who's already doing significantly better than African Americans in our community. But at the same time, we have to work harder and smarter to make certain that we accelerate the rate of improvement for Black infant mortality. That's a hurdle for somebody, because what we're talking about is improving the Black infant mortality rate at a faster pace than we're improving the overall infant mortality rate. But remember that we're also making a commitment to not slow down the rate of improvement for any group. That's a huge task. And it's part of the reason that so much of the rest of the nation is envious of the effort that we're talking about. So if we just look at the number of births, I tried to make this in simple lines. So the number of births by the 3 biggest counties in the state of Ohio. This goes from, my pointer stopped working. Oh, here we go. The bottom line here is Hamilton County. The graph goes from 2000 to 2011. This line here is Cuyahoga County. The top line there is Franklin County. What you see is that from 2000 to 2011, that the number of births in Franklin County have increased by about 3%. Now that doesn't sound like much, but that's significant because if you look at the other 2 large counties in the state, the number of births in those counties have actually gone down. And since about 2003, Franklin County delivers more babies than any other county in the state of Ohio. When we look at this total number of births by Black-white race, what we see is that for Franklin County, the number of white births has decreased from 2000 to 2011 by 13%. There have been decreases in the other large counties as well. And when we look at the number of Black births for Franklin County, that number has gone up by 24%. Cuyahoga County remains the county in the state with the largest number of Black births. Franklin County is number 2. What do those slides mean? Well, when we talk about trying to improve overall infant mortality, trying to really make a steep curve for the rate at which we improve Black infant mortality, at a time period when white births in Franklin County have decreased by 13% over this past decade, and that's the group with one of the best rates in our community. And simultaneously, the number of births to Blacks in our community have increased by nearly 25%, and that's the group with the highest rate of infant mortality. Then it just underscores some of the challenges that we have in terms of accomplishing our task. But I think it also helps to make clear we don't get to either of our goals if we don't figure out how to manage this Black infant mortality rate. Now, I mentioned earlier that we often talk about infant mortality just in terms of prematurity, congenital anomalies, the clinical issues. But there are other things that we're going to have to address to accomplish the improvement that we want to accomplish, what I refer to as the cousins of infant mortality. If we look, for example, at who pays for births by Medicaid as a proxy for the socioeconomic status of the populations that we're talking about. The solid lines in this graph are for Franklin County, but for 2010, in Franklin County as well as in the state of Ohio, about 75% of all black births were paid for by Medicaid. 3 out of 4 births paid for Medicaid. Overall, it's about 45% for whites for Franklin County, just under 35% of births paid for by Medicaid. So you can see that there's a significant socioeconomic difference in the group, and if we really want to accomplish our goals, we're going to have to work on that some. It has to be part of what we pay attention to for all of this. I'm going to look at Franklin County for a second by what we call tertiles. Very simplistic terms, what we've tried to do in this next set of slides is to look at Franklin County by areas in our county depicted in red that are thought to be low socioeconomic areas, in green, middle socioeconomic areas, the blue, high socioeconomic areas. And when we look at those areas, the slides are going to look at those 3 large counties again, but I want you to pay attention just to the middle tertile. In this slide, we're looking at low birth weight. Low birth weight is a proxy for us for those babies who are at increased risk for dying in the first year of life. You can see that individuals from low socioeconomic areas have a higher low birth weight rate than those from middle socioeconomic areas compared to high socioeconomic areas. And there is this gradient that we will see over and over as we go through these slides that associate socioeconomics with birth outcomes, where we look at the rate of preterm birth. Low socioeconomic, higher rate than middle, higher rate than high socioeconomics. And again, we see this gradient where we talk about the entry into early prenatal care. The group with the worst infant mortality rates, the lower socioeconomic group, doesn't enter prenatal care as early as we like, a little better for middle socioeconomic, much better for high socioeconomic. Maternal smoking, we see that same kind of gradient. And of course, where infant mortality is concerned, that same kind of gradient. The point in those slides is to make the connection between the rate at which we experience compromised birth outcomes and some of the things that we normally don't think about when we talk about intervention efforts. But our intervention efforts need to address all of these issues. So, again, just a reminder that our conversations about infant mortality generally concentrate on the clinical stuff. But if we really want to make inroads into the differences, the disparities that occur in birth outcomes, that requires us to take a more social determinants perspective, look across the entire life course, as Dr. Peck has already pointed out. And we have to pay attention to all of this stuff below the waterline. Because if we just pay attention to the medical stuff, the water that's already in the boat, then we don't pay attention to what wrecked the boat in the first place, what got us into this dilemma in the first place. And we have to pay attention to those things if, in fact, we want to get on top of this issue. Infant mortality. Most communities find tons of excuses for not walking through that door. They find many different reasons for not forming a task force like you have formed. They find many different reasons for not coming together and figuring out how to solve this problem. Our future is born every day. And those of us who are adults in this community, basic to all of our other responsibilities is our responsibility to protect our children. So we have to have the courage to walk through that door. We have to have the courage to figure out how to protect and save our babies. There are a lot of people who are going to say to us that it can't be done. They can keep saying it until we do it. And that's what this effort is about. I am thrilled to be here and to be a part of this work. So thank you. We have time for questions from the task force members. Anybody with questions about that? Yes, ma'am.
I have 3 questions.
Okay.
My first question is on a slide. Microphone. I should know this. I have 3 questions. On the slide that looked at Franklin County in Ohio, there's a couple of dips that caught my eye in that chart that I wondered if it's worth exploring. And there was a time in 94, 95 where our line, as in Franklin County, lowered or dipped below Ohio or got close. Then also at the time, 2004, 2005. And I guess sometimes it's easy to stop and arrest a problem as opposed to not taking the time and catching us while we're great. So I just wonder, is there any way that, or in your expert opinion, is there some value in exploring what was happening in our community, particularly those issues that are underwater that was happening at those 2 times when those numbers were at least closer to the state numbers, not close to the national numbers, but to the state numbers?
Yeah. So let me try to explain these numbers in a couple of different ways. So Franklin County, about 18,000 births every year. Of that 18,000 births, around 160 infant deaths. State of Ohio, about just under 140,000 births every year, just under 1,100 deaths. For the United States, closer to 4 million births. I don't know the numerical number of deaths. My point is that the larger the number of births and deaths, the more smooth these lines are with time. As we look at relatively smaller geographic areas, we get this sawtooth pattern, just as a matter of smaller numbers, so that you'll notice in subsequent slides that what we tried to do to smooth those numbers out, to get rid of the sawtooth pattern so much, is that we aggregated the years in 3 years so that those variations that we see that occur pretty naturally aren't so accentuated. So that's why you see in this slide that the numbers are aggregated in 3 years, and another slide they were aggregated, I think in our goal slide, they're aggregated in 5-year amounts. It's just so the numbers look more smoothly. So that sawtooth pattern that you see is in large part just a consequence of small numbers relative to the comparison groups. Now, having said that, sure, there are socioeconomic changes that influence that, but I don't know that we can measure that by the annual fluctuation that we see in our numbers because of the relatively small number compared to other groups. So everybody's been adversely influenced by the economic downturn nationwide. And generally speaking, that economic downturn is associated with a rise actually in infant mortality. And it's until recently, those slides that Dr. Peck showed that showed the improvement in infant mortality nationwide from 2005 to 2011, 12% overall improvement, 12% improvement in white infant mortality, 16% improvement in black infant mortality. Those changes occurred even in the midst of the economic downturn, so that we know just because of the economic downturn that we can still improve if we pay attention to the right things. So that was one question. You had two more?
Yeah, I do. So on the other slide where we were looking at live births and taking a look at that data, is there any value in overlapping or influence in looking at numbers of pregnancies to any of the data, both in the numbers that impact African Americans by the rate of death and the live birth? Is there any value in bringing those numbers to bear in looking at these numbers at the same time?
So looking at pregnancies instead of just live births.
What the combination of all those three things that are related, the pregnancies, the live births, and the deaths, and looking at any of the data, particularly when you bring up the issue of the births being paid for by Medicaid and the percentage of that and the percentage of the deaths, any value in looking at those numbers and making any comparisons or thoughts?
So I'm going to come at that in a few different ways. So if we looked, instead of the birth rate, if we looked at the pregnancy rate, what we don't include in the infant mortality numbers are those babies that we lose to miscarriage, those babies that we lose to stillbirth. And there are a lot of us who feel like those babies ought to also be included. What we would see if we did include them was a trend very similar to what we are showing in terms of infant mortality rates. I can tell you personally the reason that I prefer birth rates instead of pregnancy rates is because pregnancy rates include not only those pregnancies that ended in live births, but it also includes then miscarriages, and it includes abortion or elective termination. And the miscarriage rate is for the most part an estimated rate. So that if I'm trying to come to you with the most objective information that I can put my hands on, using birth data and infant mortality data allows me to exclude that estimated rate. You with me? Mm-hmm. And so that's just my bias. Others may have a different bias, but to try to provide you with data that is as objective as possible about this process, that's why it's my preference. Another question?
The second part of the overlap of the births and the death rates with the chart that discussed how the births were paid for, the Medicaid. I think there's like a percentage of 74% of.
Yeah, what?
Any correlation, or is it of any value to look at the rate of those births based on paid for by Medicaid? I'm trying to understand the value of the slide to the deaths.
Yes. Yeah. The reason for this is only to point out the socioeconomics associated with this whole process. So that if we have this group of people who, based on their socioeconomics, are in the group that is the most high risk for poor birth outcome, and they happen from an economic perspective to also be in a disproportionately high representation of the group at greatest risk, then we need to make that connection. The point is that poverty here is a contributor to what we're trying to combat. And I don't, because I don't have a way, until we drill down to the zip code level data, I don't have a way of doing that so well at the state level. I'm just showing that within a community, this connection between socioeconomics and compromised birth outcomes.
Okay. I raise that question because my fear is that the look at the impact on African Americans is hopefully not just marginalized to socioeconomic factors, because there could potentially be some numbers that share that deaths are happening for African American families, whether their socioeconomic is part of lower, middle, or high. That's the only reason why I raised that question, so we don't, I'm hoping not get in a situation where those are the only African-American babies that are faced with an infant death. That's
Yeah.
why I wanted to see
So-
if there was a value that I was missing in that. And then my last question.
Well, let me add,
sorry,
let me add a piece, let me add a piece to that.
Okay.
So if we look based, I didn't put this slide in the socioeconomic social determinants discussion. But if we look, again, comparing blacks and whites at infant mortality based on level of education, women who have babies who haven't graduated from high school have infant mortality rates higher than women who have graduated from college, okay? So education is one of those social determinants that has an influence. And if we look at the cohort of women who haven't graduated from high school, the black infant mortality rate for non-high school graduates is higher than the white infant mortality rate for non-high school graduates. The black infant mortality rate is higher for high school graduates than for black high school graduates than for white high school graduates. The black infant mortality rate is higher for black folks who have some college relative to white folks who have some college. It's higher in the cohort if we look at for folks who have finished graduate school. But in each cohort, the infant mortality rate in general for both groups has come down. It still shows that gradient that I was trying to point out. So you are absolutely correct. There's more to this than just socioeconomics, but I think most of the literature that we will put before you as this process goes on is going to suggest that of those social determinants, poverty, undereducation, and a lot of these other things that are under this waterline are contributors. And that's what makes infant mortality such a complex issue to get your arms around. It's because, as Magda pointed out, it's not just the medical, it's the all of that. And we have to decide as a community of all of those contributors what pieces we're going to pay attention to. So, I can tell you that I'm real excited about the public school education reform that's going on in Columbus. Because if that really works, if it accomplishes what we really want it to accomplish, it's going to help to improve infant mortality. If we really get serious about unemployment for those who've been traditionally out of the employment circles, it's going to have a significant impact on infant mortality. If we improve the quality of life in neighborhoods generally, it's going to significantly improve infant mortality. There are so many pieces to this. So the only point that I'm trying to make is that it's not just medical. Right. And I hope as time goes on, we'll be able to get into that a little bit more. But
Yes.
Sort of, okay.
Yes.
Other questions? Looking for the time because I don't want to get in trouble.
We're ready for our panel discussion.
Okay.
Thank you,
Thank
Dr.
you all very
James.
much.
Next, around the mission at hand, and I guess just a comment, closing comment. The slide that impacted me the most was the chart that shows the U.S. against Ohio against Franklin County. You know what? We can do better. That is just plain not us. So, and I also appreciate your closing comment about education. So, Dan Good, there's another mission for you. We're glad you're with us as well. So with that, Dr. Peck is going to lead a panel discussion for us, and I'll turn it over to her for the next part of the program.
While we're waiting, I think it'd be really helpful just to take a breath. It's a lot of stuff. It's a lot. And while we're waiting for our panelists to fully come up and get wired, is there one or two other pieces of information or something that you've heard so far this morning that stuck with you? Like an aha. I'm just looking for our task force members. We heard from Michael. Is there something that just like wow or And introduce yourself again for the folks in the back that may not see you, Mr. Good.
And to Michelle Mills' contribution, to me, the cross-tabulation of some of those variables we're looking at would be really helpful, because I think it does help us to dispel that there's causality between some of those factors and the infant mortality. And so that is data that would be appreciated in the future.
And the thing that comes out of that I encourage you to do is lead with as many questions as you have. What more do you need to know? Because there's so much data out there. But the questions that you ask will be more important and frankly more powerful than just having data thrown at you. So that's one. And we have the technology now to do overlaying in geographic information systems where you can look at segregation or housing and school achievement and begin to see it both in population and in place and in time. Very powerful. Is there one other thing? Donna.
I'd really like to see, and I know we can make this happen, more understanding of the correlation between infant mortality and a healthy community. I mean, we hear that term constantly, it's tied to this, to this, to this, because I think we have to, while we stay focused on this, have this overarching understanding that this is a key indicator of something that has been allowed to sort of atrophy in our community over time, and now our babies are the canaries in the coal mine, so to speak. So I want to make sure we don't lose sight of that, because I think part of having a sustained effort around this will not just be about infant mortality per se and those numbers when we get them down, but what are these other determinants that we have to stay on top of? And the second thing I'd like to understand that this conversation has piqued my interest in is the notion of the cost of prevention, the cost of dealing with the social determinants as compared to the cost, the clinical cost of the prematurities. Because I think we have to get our heads around where we are investing financial resources, and if hospitals and doctors and families and insurance companies are having to pay for this on the back end, on top of the heartache and the misery and the pain that you go through personally, what would the cost have been of dealing firsthand with some of these social determinants, the right ones that are appropriately correlated? So those are the two big ahas I've sort of set aside for myself.
So put the economic analysis out there, not only the return on investment, and you also could look forward, given the Affordable Care Act now has a set of preventive services for women that have never been defined before, and I had the privilege of serving on the Institute of Medicine panel that created that set of additional services under the Affordable Care Act, including well-woman visits. So the idea that the preventive visit is paid for. We can deal with the contraception work over here. I'm really happy about the visit itself to get her in the door, particularly between the first pregnancy and the second pregnancy. There's some opportunities to drill that down by population and by time. And if we pick out particular folk and particular windows of time, that big complexity can be a little more focused. So two more pieces. Before we get to the panel, is there one more aha that you had? I'm going to take one over here because I want to make sure that we're just making sure that things stick and don't get blurry-eyed. Let's hear it from Ms. Mills.
I would like to see our PPOR. I would like to see what that picture looks like. I know what it is, and I just haven't looked at it in a few years, and I think that the task force would benefit from looking at it. That's all.
I happen to be able to answer that one, as you well know, given that our colleagues and I are
could
the
you
ones who
separate those two
created
ladies
it.
over there?
PPOR, very brave people, perinatal periods of risk. The slide that I showed that had a blue box and a pink box and a yellow box and a green box, it sorts out not just infant deaths, but something that hasn't been spoken of here, which is also the power that might come in, more data, which is fetal deaths, stillborns. Babies that die in the 6th, 7th, 8th, 9th month of pregnancy. I'm not talking about the younger, but post-viability. If you combine the fetal deaths and the infant deaths together, and you sort them out about when those babies died and how much did they weigh, fetal and infant, you get to see the picture I showed you before about are they these babies that die, are they these babies that die, are they these babies that die, or are they bigger babies? It's 4 different kind of snapshots, and then why, and a whole methodology about disparity and further analysis. And it was done, I noticed Carolyn Slack was in the audience here, former Director of Maternal and Child Health here for Family Health here for Columbus. It was done about 10 years ago, one of the foremost cities to start this methodology. Might be helpful to go back and look at that lens again to help that sorting out. It's like Hogwarts and you know, which hat do you wear? They sort it out so we can know which babies we're talking about. So PPOR, easy to do, and I think the idea is putting it now in a fresh context. There may be others, yeah.
Franklin County Commissioner.
Thank you, Mr. Grady.
We came to Anthony Trotman, the Director of Job and Family Services, and I came to this task force with our eyes wide open, knowing and understanding the involvement of Franklin County and what we've done over the years, the involvement we've had with Nationwide Children's Hospital and the $7 million investment there, and the level that we serve, the client base that we serve is this. But I think as each layer of the onion's been unpeeled this morning, it's the aha for me has been just through, for instance, the St. Stephen's Community House and our partners, and the level that Franklin County government touches this problem is even, I think, greater than we came to the table understanding, and we came to the table understanding it very well because we deal with it every well. We've made the investments, we know, but I have a feeling that over the next 6 meetings we're going to have even more of an aha understanding exactly the numbers of the clients that we serve that are impacted here, and that the level of impact that we will have going forward, hopefully on this project.
It's that notion also of knowing the denominator. We may talk about 150, 160, 170, 180, or 18,000 births, but to connect them to the women, children, families, and fathers that you serve already in the public school system, in the county social service system, in the private sector in terms of your employees. Who are we talking about? Which is why we talk first about the babies. Then we need to ask about their moms, their dads, their aunts, their uncles, their sisters, and their future grandchildren. So love to peel the onion. We can get this. It's not too hard, but it is complex. We have a way of getting at it today by having some insights from 3 colleagues who bring diverse perspectives to today's table. I've been called the Oprah Winfrey in public health, and we were born in the same year, the year of the horse, which is good because today is Chinese New Year, so it's going to be the best year ahead of prosperity. I'm going to facilitate them one so we can move ahead and get it done, but to add a little bit more story behind it, particularly in terms of, so what are we doing? Not just what the numbers are. I'm going to ask each of them to take literally just a minute and make sure they tell you who they are, number one, even though their bio's in the book. Just a snapshot in terms other than it's there. So, who you are and why do you think you're here. And then I'm going to come back at you again and ask for your 5 minutes, and this is a real 5 minutes, of the story that you want these folks to hear as we're layering in what we need to know in order to do this thing better well together. So I'm going to start, if I could, with Reverend Edgar. Would you introduce yourself, tell them in terms that these folks, besides your bio, need to know about you and why you're here.
Sure. My name is John Edgar. I'm a United Methodist pastor, and I head a nonprofit called Community Development for All People that works with high-risk folks on the south side of Columbus. I think I'm here. I'm not a medical professional. I don't have a lot of expertise in public health, but I have worked with many of the organizations that you represent. And what we're good at, and what I believe ultimately needs to happen more, is to figure out how these concepts get lived into the interactions in the community, how there are partnerships, and that's what we've been doing and believe more can be done.
We'll hear more about that. Thank you. Would you join me, please, in welcoming Reverend Edgar? Thank you. Our second mystery guest, not a mystery at all. Ms. Roberts, introduce yourself, please, in terms that they need to hear.
Well, good morning, everyone, and welcome to Columbus Public Health. My name is Dr. Mashika Williams-Roberts, and I serve as the Medical Director and Assistant Health Commissioner here at Columbus Public Health. And I just want to pause for a second and tell you, your presence this morning is really a testament to what this community thinks about our health and our well-being. We at Columbus Public Health have been working on this along with our hospital partners for many years, and I think your presence not only around this table but out in the audience gives me hope that we can find the solution and we can reach the goals that President Ginther shared with us this morning. So thank you again. And I think I'm here on the panel to share some of the work that is being done to help reduce infant mortality here in our community currently.
Thank you so much. Join me, please, in welcoming Ms. Roberts. Thank you. Our mystery guest from Omaha, Nebraska, someone I've known for some time. If you could introduce yourself, Mr. Abrish.
Good morning, everyone. My name is Chet Abrish, and I have the privilege of serving as Executive Director in the organization that Magda founded, CityMatch. We're a national organization that is dedicated to maternal and child health. We represent local health departments, and today I'm going to be focusing specifically on the inequity because our founder put at our soul really a bent towards social justice. It's who we are.
Thank you. Please join me in welcoming Mr. Abrish. I'm going to start first with Ms. Roberts because I want to start where we are. We are in the health department, and government has a role to play, not exclusively and not unilaterally, but it's a critical part of being for the public's health and vitality. Tell us in no more than 5 minutes, and we're watching the clock, the most important stuff that they need to know first about your work.
Okay. Well, thank you, Magda. Let me first by sharing with you a few collaboratives that are already occurring here in our community because of the good work of not only public health, but also our hospital systems. And you'll hear more about them probably through your 7 meetings, but I just want to touch on them so that you're aware of them. We have a statewide organization called OCPIM, which is the Ohio Collaborative to Prevent Infant Mortality. And I want you to know that there are members from Columbus Public Health, members from Franklin County involved with that, as well as partners from all around the state. Locally, we have a group called OBO, Ohio Better Birth Outcomes, that is managed by Nationwide Children's Hospital, which many of us are a part of. As a result of that work, we have been able to bring 17P and make it more accessible to our community. I'm surprised I don't hear any knocking of what 17P is, but 17P, also known as 17-progesterone or progesterone, is a hormone that we are able to give women to help them carry their babies longer, to prevent prematurity, prevent them from going into labor sooner than we want them to, and so they can increase their chances of having a healthy baby. We also have a child fatality review that looks at not only children who die in our community, but also our very young children who die in our community. It's a collaborative with the police department, the fire department, the coroner's office, many social services agencies, hospitals, and we look at each death of a child that dies before they're 18, and we look at solutions and how we as a community could have prevented that death if possible. We also have a local group called COMAB, which stands for Central Ohio, Council of Healthy Mothers and Babies, and as a result of that work, we have a service called the PCC, which is Prenatal Care Connection, which is a centralized number for women, particularly women who are on government-assisted insurance. You saw the slide that Dr. James showed you that almost 75% of our babies here in our community are born on using Medicaid. So that system, that service is available, so there's a centralized intake process. So when those women are pregnant, they can call that number and get connected to care. So that's just a few of the services that we offer. I'm sure there are more, and if you're in the audience and represent a group that I didn't mention, I do apologize, but I wanted to just give a high-level overview. I want to start by talking or responding to Councilmember Mills' question earlier about the PPOR, the perinatal periods of risk. And we have done that assessment for Franklin County. And what we've learned from that assessment is one of the areas where we can make the most intervention is in the mother's health, so maternal health. And so thinking about that in terms of programs that are currently offered here in our community, we're very grateful for the Affordable Care Act. We're very grateful for Medicaid expansion because we know as a result of that, that will get more women into well woman care. More than 50% of pregnancies here in Franklin County are unplanned. That means a woman gets pregnant and she had no intention of getting pregnant. And as a result of that, she might not be in the best health status to carry that pregnancy to term. If we can get women into well woman care before they get pregnant, make sure that their diabetes is under control, make sure their hypertension is under control, make sure we address their obesity. And we know we have a huge obesity problem in our community and in the nation. That is important to make sure that when that woman does get pregnant, she has the capacity to carry that baby to term and have a healthy baby. So we, as well as many of our partners here, the hospitals, the federally qualified health centers, we have well woman care that we offer here at the health department. We make it accessible to women who might not have the resources to go to a private physician, but because of the expansion of Medicaid as well as the Affordable Care Act, we truly believe that there will be more women who will have access to well woman care, and as a result of that, we will see some reductions in our infant mortality rates. I think I have just a few more minutes, and I want to talk about what happens. That's what happens before pregnancy. So let's talk about what happens and what services we have during pregnancy and post-pregnancy. First of all, when a woman is pregnant, we have access to prenatal care. We have many, many providers in our community that provide excellent prenatal care. So we're very fortunate for that. But we know that women who are pregnant need more than just medical care. And many of them need the wraparound services, the social support. And we offer that through many of our programs. We have many home visiting programs. We have case managers. We have social workers that help a woman realize what other services she might be eligible for and that she needs to make sure she has a healthy pregnancy and a healthy baby. And then I'll talk about postnatal care just briefly. And that we have home visiting programs. There are 3 agencies in town that provide home visiting. We're working together. We've been doing this for the last 6 to 9 months to see how we can provide some of the same services to make sure that women in our community who do get a home visit get the same quality of home visit no matter who the funder is. Currently, there are over 5 funders that are providing this service, but we're trying to provide some quality and unity in terms of those visits. And then last but not least, I would be remiss if I don't talk about safe sleep. And we know that that is a major driver for infant mortality. We have services in our community where we give out cribs, we give out playpens, pack and plays for women to use. But I want to caution in saying that just giving a family a crib or a pack and play is not enough. And what we've learned through our work is that we have to not only educate them about safe sleep, but many times we have to put the pack and play together. If any of you have ever tried to assemble a pack and play, which I admit I have not, but I hear that they can be somewhat challenging at times. So we've learned that we've given pack and plays to some of our patients, and we've gone back 6 months later, and we've learned that there was a death in that home, and the pack and play that we provided them is still leaning against the wall in the same place we dropped it off. So as a result of that, we now make sure we not only deliver it, we set it up, and we put it in a room in their house that will be appropriate for their use. So I'll stop there, and I apologize if I went over time.
That's great. A lot of things going on. We celebrate them. This is within the traditional and expanded concept of what public health can do, which is created the conditions for everyone, every day, everywhere, to have equal chances and fullest choices to be healthy and well from generation to generation. Long-standing work in this health department. It's not the only place that public health happens. And in fact, everyone here, you'd say, well, I'm not in public health. I'm going to beg to differ with you, Reverend, because exactly. But you are an expert within your world, and I think from that expertise in the broader system for the public's health and well-being, of which all of us are part, let's get a different story for 5 minutes about what's happening in community development for all people. Reverend.
Sure. Where I want to begin is to just affirm that I'm just so impressed that you all have come together. I think the opening presentations have been remarkably effective in reminding us that the infant mortality rates in our city, on the south side where I live and work, they're obscene. It's just absolutely unacceptable. And so it seems to me that where we start at is to say, so what are we now going to do about it? What will we do to ensure that, at least in terms of the mission, is that every single child, as President Ginther said, will celebrate her or his first birthday. If that's what we're about, then I think it gets intriguing to talk about, in addition to all the incredible research, the issues of best practices, I think it comes to how does that get lived into, woven throughout the community. And that's where I comes with unwarranted optimism as well, because I think there are a couple of indicators that suggest we really can take this from the abstract and get it lived out at the neighborhood level. And so I want to highlight that in a couple of ways that I think are interconnected. First of all, I think the reason I got invited to sit here is because the organization that I lead actually has figured out over the last decade or so how to partner effectively with a lot of you in ways that are having impact on health and wellness. I mean, we team a lot with the anchor institution in our own backyard, which is Nationwide Children's Hospital, and we do things with them, everything from developing millions of dollars worth of affordable housing, but what they talk about is healthy neighborhoods, healthy families, a five-prong attack that looks at upstream factors that impact health. And then alongside of that, as we've been working with them, we have health and wellness initiatives that we call HEAL, Healthy Eating and Living. And they involve not only Nationwide Children's Hospital, but Columbus Public Health, The Ohio State University, Ohio Health, Mount Carmel Cardinal Health. And we are figuring out sort of as we go that we can indeed take these best practices and work on them, tweak them, and live them out at a neighborhood level. And we're trying to do that in a general way, and it seems to me that the related reason for incredible optimism is that you now are helping all of us focus on what, as some of you have already said, is truly the single most important public health issue. It's the barometer of community health, and also as a community, we have to be able to say that we will care for those who are the youngest, the most vulnerable, the most innocent, and it is a challenge that I think you will see the rest of the community respond to. I honestly believe that mosques and synagogues, local churches, neighborhood associations will be thrilled when you give us the specific game plan and say this is what we should do next. I think in many ways we are anxiously awaiting that because there's a kind of general rumor, rumble out there about how bad it is, even if people don't know the specifics. And then one other thing I want to say is, when I talk about it becoming very basic, I love what Dr. Roberts was saying. You can drop off equipment, but if it's not assembled. But I even want to make it even simpler. My wife is on one of the groups that's working to lower infant mortality on the south side, and she was recently showing me these little onesies for newborns. And there are some now that come with instructions on them. One says, I sleep best alone on my back and in my crib, ABC. The one I like best has just 3 words. It's printed across the front and it says, this side up. So when you put me down, put me on my back, this side up. But what I want to go with that is, that's awesome, it's wonderful. But if those onesies don't get onto those babies, what good do they do? And by extension, what I'm convinced of and what I want to push more than anything else is that if we get the whole community at the grassroots level knowing ABC, alone, on my back, in my crib, if the whole community is reminding folks, babysitters, grandmothers, aunts and uncles, that this stuff matters, that you really need to stop smoking if you're pregnant and all the rest of that, I think we have to create a movement, and we're capable of it, that says we're in it together. It's the whole community's issue. And if we pull that off, then we'll do the thing that will ultimately win if I hear the experts right. Ultimately, it has to be the upstream factors. And if the whole community gets involved, and we see that we can't achieve the full mission that every baby has a first birthday until we deal with public education risk factors, the fundamental legacy of racial discrimination. It may not be as appealing, but once the whole community says we care, once we're in it together and we still face challenges, I think we will widen our perspective. And the kinds of things that Nationwide Children's Hospital is doing, saying we want healthy neighborhoods to have healthy families, will be the cry for the whole community. Okay.
Thank you. So 2 voices of full court press, place-based work, so where you are, who you are, everyone on board, a sense of optimism. Let's take a look now at a national perspective. One of the things that CityMatch does is that we look at every possible city in the nation of about 100,000 or greater. That's a lot of cities, 200 and some cities in the country. So we're in good company, even though if we're number 15th here in Columbus relative to infant mortality. Mr. Abrish, tell us a little bit about a broader perspective. Help us zoom out of Columbus to Ohio, to the nation, and give us an urban lens and some marching orders.
I'm glad you asked me to do that, Magda, because that's what I prepared.
That's good, in 5 minutes.
Let me start, though, with just a quick story. I have to give a compliment to the governor, and I hope you'll pass it on to him. CityMatch is based at the University of Nebraska Medical Center, and I guest lecture a class in maternal and child health. Part of what they asked me to guest lecture on this year was the Medicaid expansion. So I really wanted to create independent thinking and thought among the students. So what I did is I went out and I found 5 different either press conferences or interviews of governors that were either deciding to do the expansion or not do the expansion, and why. And I showed them to the students and then tried to generate conversation after. And so after I had shown the 5 videos, I said, okay, so what resonated with you? What did you really like? And immediately a hand went up from a young student. And she said, well, I liked Ohio's governor. And I said, oh, okay, why? And she said, well, I guess it's because he put people ahead of politics. I thought that was awesome. So thank you for that. And by the way, I did hire her the next week. She is now a GA at CityMatch. So I was sitting over there on the side of the wall, and I have to tell you, I was really nervous. 1, because this is a very esteemed panel. And 2, we're clearly in a chapel, and I thought I was going to be up there, which it looks a lot more like a pulpit than a podium. So I was a little nervous. But I do want to preach just a little bit today. Magda put up some data and statistics that came out of the National Center for Health Statistics just last year. That study was published in April of 2013. And as you saw on her slides, it heralded some pretty good news over a fairly long period of time. Number 1 piece of good news, infant mortality was down 12%. Number 2 piece of good news was that the Black non-Hispanic rate was down 16%. So we're seeing closure in the gap. And there was a 3rd piece of good news in that report. It was that we are seeing gains where we needed to see gains the most, meaning that some of the states with some of the worst rates were seeing some of the best gains. So I would encourage us, though, that the right thing to do right now is to keep the champagne on ice. It is not time to celebrate, and a couple of reasons why. Number 1, I said that the report indicated that by and large we were seeing progress where we needed to, but that was not universally true. There were some southern states where we needed to see progress and we just didn't. And closer to home, there were some Midwestern states where we really needed to see progress and we didn't. Ohio, of course, is one of them. So having read that report, I got really curious, and we have a great group of epidemiologists at CityMatch. So I asked one of them, Carol Gilbert, if she could look at that trend in declines and project out what Magda also shared on that slide, when we would get to parity. That was my question. When will the white infant mortality rate and the Black infant mortality rate be equal? And I was a little nervous taking this request to her because it's, other duties as assigned. But what you have to understand about Carol is that she calls herself a math geek. So instead of being angry, her face lit up when I asked her to do this. And she immediately said something to the effect, do you want me to use a least squares linear regression? And I said, how about if I just check back with you after lunch? So when I checked back with her, I have to tell you, though, that what we found was disturbing. So she projected out those results, 3 findings to share with you. Number 1, the Black infant mortality rate at the present rate of decline stays in the double digits, meaning at least 10 deaths for every 1,000 live births until the year 2023. Number 2, and this gets even more concerning, the non-Hispanic Black rate does not reach the Healthy People 2020 goal until the year 2042. And then lastly, the non-Hispanic Black rate and the non-Hispanic white rate do not meet until the year 2063, sometime in the year 2063. And when she shared that with me, there was just one phrase that kept ringing through my head, which was not soon enough. It's just not soon enough. I think everybody would agree with that. So City Match went out, and we were really excited to find that that URL had not been purchased. So today, you can go to www.notsoonenough.org, and you will find a blog site that is an online conversation about how we can speed up justice in birth outcomes. And I would ask you, actually I would implore you, to go out to that site and post your comments, your passion, your drive. Right now, we just have our board members, and we can just send emails to each other if it's just the board. We know the board cares about it. We need people around the country saying this is an important issue, regardless of when, it's not soon enough. So please visit www.notsoonenough.org. I want to share one last thing, and that's the fact that in addition to doing that site, it also prompted us to do a quick survey with our members. And this, I hope, is valuable to you. We sent the survey out to our members, and we asked them a few questions. Number 1, we know we're seeing progress nationally on the disparity, but in your local jurisdiction, are you seeing progress? And then among that subset that said yes, we asked them exactly what they were doing that they thought were driving those declines. I've provided that list to Jesse and Julie, and they're going to make it available to everyone. And hopefully, to make it a little more valuable, I also classified all of those programs from the jurisdictions that are making progress according to a new triangle that Milt Kuttlechuck developed just last year. If you know Milt, you know that he never met a triangle he didn't like. And you also know that he's a brilliant MCH person in the field. He came up with a really simple triangle for us to think about our reproductive health programs. It has 3 domains. The first domain, bottom right-hand corner, is clinical strategies to reduce the disparity or to reduce rates in general. The top of that pyramid is resiliency efforts. So what can we do for mom and families to empower them to do for themselves? And then the bottom other part of the corner is the social determinant strategies. So what are those root causes that we need to change that are in the way of us getting to progress? So this triangle, I think, is really helpful to you, and as you start to think about how do we design our efforts. When we put together a safe sleep initiative, how do we make sure that, yes, we're in the social determinants quadrant by providing cribs, but we're also up in the resiliency quadrant or domain by teaching and educating and helping to show how you put it up. And in the clinical domain by saying, we have clear messages in every hospital and consistent messages in every hospital that this is what safe sleep looks like. So let me stop there. I'll pass it back over.
So we have some amazing local strong work happening within traditional public health, broadly defined, community work, broadly defined, and affirmed by a national movement that puts Columbus in really good company and perhaps on the leading edge with some resources to use. To respect our time as we go to our closing, then allow me to summarize and pass off the closing comments to our co-chairs. Would you first so just join me in thanking Mr. Abrish for his remarks. So my mother's name is Thelma, You don't mess with Thelmas. It's a very strong name, very old-fashioned name. Anybody know a Thelma? Do you know what I'm talking about? Mm-hmm. Thelma will be 89 in about 2 weeks, and you don't mess with my mom, so I'm the mild-mannered one in my family. When I took the job as the founding dean of a brand new school of public health in the hardest city in America, I call it the Sentinel City of America, without enough resources in a public institution, without a strong clinical base, all the things you could say, are you nuts to do this? She sent me a box. No note. 3 things in the box. I'd like to tell you what's in the box as the metaphor for what I think will be helpful to the task force and summarizes what these folks brought today, as well as Dr. James before him and the other speakers. The first thing I pulled out was my mother's 1948 Master's in Social Work thesis from the University of Pennsylvania about family systems in neighborhoods to protect children and families. I never saw her thesis before. She gave it to me to be able to hold it to the next generation. Research, learning, stewardship. Pull out the second thing in the box. It's a graduation hood of the regalia of academe. And it comes as the hood she wore at the age of 75 when she got her 3rd master's degree in divinity. Social work, anthropology, divinity. And she wore it as the oldest graduate of Berkeley's Starr King Unitarian School, as a proud Jewish woman. And from that I took that not only does it take good research one time around and good data, but you got to always be open to learning and reframing the issue from something specific to something divine. The third thing in the box was this itsy-bitsy, teeny-weeny little bikini, purple and white stripe. I pull it out, and I think, are you kidding, Mom? Like, what are you thinking? I mean, I haven't worn a bikini in, before, the earth was founded. And I hold this thing against me, and I'm thinking, what is this about? And then I thought, she still believes I'm going to lose that weight. She believes that it is possible for me to wear this bikini. She's not expecting me to look perfect, but she still has hope. And then there was something else in the box. I reached in. It was one of these men, forgive us, but it's a thing that you wear over a bikini that you don't quite fit into. It has a little blousey thing, right? So you don't have a little skinny top. It's kind of like baby steps towards bikini, because she knew that I wouldn't wear this one by myself, that I needed to have some things I could do before I got there. What I leave you in this metaphor is, what you've heard today is that there's data, research, evidence, practice, evaluation, aggregate layering on of stuff to make us look across sectors. We have more no stuff available to Columbus that will inform the work of this task force and pull in community engagement. 2, this is a community that learns together. If you learn together, you can act together more powerfully. And so I applaud you for the 7 future meetings in which you're going to become a different kind of expert and advocate for the public's health, because you have a common knowledge base to work. So keep on learning, even if you're 75. And learn outside your field, because whether you're clinical or not, it's the combination of our disciplines that you've heard today that'll pull it together. And third is dare to believe that it is possible. Because if we do not have that faith, that belief, that audacious, hairy goal, and say we must, in this place, in this town, at this time, And we're not waiting to 2063, let alone 2025. And we have missed a generation's generation. I want to thank you for listening to our panelists here give their perspectives of those three. Please join me again in thanking them for their wisdom.
We approach the moment of wrapping up. I want to thank our panelists and our speakers. I want to thank all of the members of the task force and those who came to hear and be a part of us kicking off this effort in our community. As I talked about earlier, you know, a lot of these meetings, especially this one, will be about education and information, sort of. You got to set the stage of where you are so you can understand also the possibilities about where we can go, and then really solutions that we can embed across the community and in the organizations that we represent collectively and individually. So the hope is that today you leave here with a better understanding of the problem, the potential solutions, and I also hope with some questions. Maybe not in the moment you wanted to voice, but please get those questions to us, especially if it's information you would like to see more of or to better understand. Because if you don't have that grasp and don't have that common understanding, we're going to miss the opportunity to close the gaps that we identify. All the materials for the meeting today and a summary of the discussion will be posted on the website, including a link to the video version of the members of the public who are interested but could not attend. And also check the website for where we're having our meetings around the community. And again, I encourage task force members to sign up to be a part of some of those meetings, because we need to hear and embed ourselves in our understanding of what's going on in this space. Our next meeting is just 2 short weeks away. It'll be here before we know it, Friday, February 14th. Is that Valentine's Day? Well, we're going to have a lot of love on that day. At 9 a.m., it will be hosted at Nationwide Children's Hospital. So check the website for that meeting and our future meetings. And I would just offer, are there any closing comments from any of the task force members or my co-chair? I know you're between everyone else and lunch as well. So with that, I want to thank all of you, and I wish us all continued effective effort in this space. Thank you.